Can we start?
Yeah, we start in 30 seconds, sir. We are going live. Okay. Good evening, everyone. Welcome to today's chapter in this series of masterclasses brought to you by IASO Academic Council. The topic for today is neuroendocrine tumors of pancreas. I invite the convener of the Academic Council, Dr. T. Subramanian Rao, to kindly deliver the welcome address for today. Sir.
Good evening. It has been a great privilege and pleasure to be heading the Academic Council of the IASO. It all started during the COVID time when the President and Secretary, Dr. Arnav Gupta and Dr. Sharad Desai, initiated this series of masterclasses and asked us to do this on a regular basis every fortnight. We have actually done about 25 masterclasses last year in the first segment, and in the second segment, this is the 15th one. So that makes it 40 masterclasses. All of them are on the YouTube, watched on a regular basis. So we understand that this has been a serious contribution of IASO, and this effort is being continued by the current President, Dr. Rajendra Toprani, and the Secretary, Dr. Chandramohan. We thank them and appreciate their efforts in furthering academics in IASO for its members, both the faculty and the students. We have three very academically oriented experts from across the country as the faculty for this masterclass. Dr. Rajesh Bhojwani is a very popular name in the academic and surgical circles in the country. He is the Director of Surgical Services, Santokba Durlabhji Memorial Hospital, Jaipur. He is the founder and the head of Santokba Institute of Digestive Surgical Service Sciences and the Program Director of the Dr. NB Surgical Gastroenterology in the same hospital. He is also a Program Director for Fellowship in Minimal Access Surgery in SDMH, Jaipur. He has 24 publications in national and international journals and 8 chapters in various books. The second examiner is Dr. Sandeep Naik, once again a very popular surgical oncologist, very prolific surgeon. He's a professor and head of Minimal Access Cancer Surgery Unit and the Director of Surgical Oncology, Max Clinic and Fortis Hospitals, Bangalore. He has multiple innovations. He has been very active in minimal access surgery, robotic thyroidectomy, the rabbit, and neck lymph node removal for head and neck cancers, and then the technique for groin lymph node removal. He has multiple awards and numerous publications. Ranveer Mantri is a professor of nuclear medicine, once again a very, very academic in his approach, and a very, very passionate teacher. He's a professor of nuclear medicine at the MNJ Institute of Oncology and Regional Cancer Center. Was a key member in developing infrastructure and human resources in the nuclear medicine department of Sri Venkateswara Institute of Medical Sciences, Tirupati. He started PRRT therapy in the state of Andhra Pradesh, has multiple publications, and is specifically interested in endocrine oncology, and that is the reason why he is here with us. Welcome, gentlemen. We understand that we will learn a lot from your experience and wisdom.
Thank you, sir. The examinees for today are Dr. Mithun Mohandas, who is a resident in the Department of Surgical Oncology at the Regional Cancer Center, Tiruvanthapuram, and Dr. Kush Pathak, who is a resident in the Department of Surgical Oncology at Hinduja Hospital, Mumbai. A few basic instructions for the webinar session that we are having today. For our examinees, we kindly request you to give to the point answers to the questions being asked. It's never expected that you know everything. So there's no harm in mentioning that you don't know something, because it saves us time and it maintains the flow of this webinar. And the examiners do have a habit of giving hints. So it's up to you to read their body language and catch what they're hinting at. For our moderator, Dr. Sandeep Nayak, today, we request you to please address the examinee by the name to whom the question is being directed. This avoids confusion amongst the two and they know who is supposed to answer. And we also request you to ensure that both get equal opportunity to answer in the next 1 hour. For our examiners, in interest of the online viewers, both online live today as well as people who are viewing this on social media later on, we request you to give the expected answers to the questions that have been incorrectly answered or remain unanswered. And for the participants, we see a few senior ISO members in the meeting today. We thank you for your participation, and we request you post in your inputs as well in the chat box. For the residents, it's a unique opportunity to get all these experts in the field. Please make full use of it. For timekeeping, from my end, I'll be reminding the moderator via chat at 45 minutes and at the conclusion of case discussion, which would be at 60 minutes. Over to you, Dr. Nayak.
Thank you, Dr. Srijan. It is thanks for the introduction and putting the things in perspective. Let me first share my slides. Can you allow me to share? Yeah. So my slides are visible?
Yes, there.
Yes. Okay, so on the outset, my sincere thanks to Subramanyeshwar Rao sir for involving me in this program. So sometime back he had asked me and I had told him, no sir, you involve all the seniors and then I'll come into the picture. So he did it. So finally, he has given me the opportunity. So today, in addition to what already Srijan has told, to the instruction to both the Mithun and Khush is that you are going to be consultants in surgical oncology. You're not are not PGs. You're approaching the exams, and next you will be having your own patients to treat, and you need to think like consultants. And today's discussion will be keeping to the theoretical, but it's predominantly about the case that we are discussing, and we may go here and there in between to understand your knowledge about the subject, but you need to stick to the case that is being discussed and think like a consultant. Think as though you're going to treat this patient has come to you. So that is very important. So the first case that we are discussing is a 60-year-old lady who has come to us with history of dyspepsia for 2 months and occasional epigastric pain, and no history of there is no history of vomiting. Examination, there is no specific findings. Abdomen is absolutely normal on examination. No other clinical findings which we found. And in the examination and history, do you want anything specific from us? This is to Mithun. And then followed by that, I'll be asking Khush also.
Sir, in examination, I want to know whether there is any, since the patient is having upper epigastric pain, I want to know whether the patient is having any mass in the epigastric hypochondrial or...
No. Otherwise, it's all normal.
Normal, sir. Okay. Whether...
See, my question does not mean that, you have to have a question, but, I'm just asking if there is any specific thing which you want to know. All those examination findings are negative.
Yes, sir. If everything is normal.
Okay, we'll go on. Anything for you, Khush?
No, sir. I'll move ahead, sir.
Okay. So blood parameters are also normal. We have done, including LFT has been done. Everything is normal. But an ultrasound. See, this is a clinical scenario. Patient has come because this is not a typical examination case for you, but it's a pure clinical, when you're sitting in your consultation chamber, this kind of a scenario can arise. An ultrasound report which suggests a lesion in the uncinate process. Now, my question to you is, What next? What would you do next? This is to Mithun.
Sir, I want to know the further details of the ultrasound, that lesion, sir. I want to know the size of the lesion. I want to know the character of the lesion, whether it is a cystic lesion or a solid lesion, and what are the, whether it is a regular, irregular lesion, ill-defined lesion. And I want to know about the nature of the associated structures like CBD, pancreatic duct, rest of the pancreas. These things also I want to know from the ultrasound if possible, sir.
Okay, see, there is no dilatation of the CBD. There is no, mass size is about 2 into 2 centimeters. They have not been able to, it's a vague mass. They have not been able to describe the, other characteristics of the mass.
Okay.
Now, by far, that is the information which you have, because what is the limitation of ultrasound in, for pancreas?
Sir, ultrasound as such is we have it is difficult to assess the pancreatic lesions because we will have the stomach shadow overlying the pancreas. Most of the time, the content of the stomach, the fluid or the gas in the stomach will be hindering the vision of the pancreas. So,
is it the fluid or the gas?
Gas, mostly gas in the stomach, which will be hindering our visualization of pancreas during a routine ultrasound, sir. So.
Okay.
So which investigation with which mode of ultrasound will help you to prevent this, and which will be your next investigation?
Sir, routinely we practice like when a patient presents to us with an ultrasound detected suspected pancreatic lesion, we will go for a CECT triple phase pancreatic protocol of the abdomen, sir. In order, sir.
1 minute. See, patient has come to you with dyspepsia. You want to think something else before you go direct for CT scan?
This patient, because the patient is having dyspepsia and upper epigastric pain, I also want to do an OGD scopy in order to assess because this new onset dyspepsia and epigastric pain is always a alarming, a red flag sign of any stomach lesion also, sir. So I want to do an OGD scopy also in this patient, sir.
Okay, so your first investigation would be OGD scopy?
Yes, sir.
Okay, it is normal.
Yes,
what next? I'll go to Kush. I think we'll ask Kush what would you do next?
I would like to do a contrast enhanced CT scan of the abdomen in a pancreatic protocol, sir. A triple phase CT scan of the abdomen, sir.
So, triple phase. What is triple phase for pancreas?
So, triple phase of the pancreas involves the assessment of the pancreas in the arterial, the pancreatic, as well as the portovenous phase. So, arterial phase is usually 10 to 20 seconds from the time of injection of the contrast. The pancreatic is from 30 to 40 seconds, and beyond 50 seconds is the portovenous phase.
Is there any slide where you want who answered that? It was Kush or sorry, I missed who answered the question now?
I answered, sir.
Okay, so you want to change anything, Mithun, about the phases?
Sir, routinely in pancreatic protocol, we usually go for a late arterial phase rather than an early arterial phase because the pancreatic lesion routinely enhances more in a late arterial phase. So we get a plain CT, a late arterial phase, a portal venous phase, and these are the three classical phases that we go for, sir. The late arterial phase is typically around 40 seconds, and portal venous phase around 60 seconds. Sir.
Okay.
May I interrupt?
Dr. Bhojwani,
yeah. So I would just like to point out, Mithun and Kush, of course, it's taken for granted because the history was given briefly, but I think as a specialist, you should have probably asked the history for diabetes, because the history of diabetes because, we are discussing NETs. So history of diabetes would have been important. That is one. Secondly, on the ultrasound, you should have specifically asked about the size of the lesion, because you know that it is going to have a bearing on the later workup as well as treatment. And when we talk about pancreatic protocol CT, it is known as pancreatic protocol CT. It has three phases. It has one arterial phase, second is the pancreatic phase, and third is the portovenous phase. Now, the arterial phase is specifically to pick up enhancing lesions, whichever are the vascular lesions. Second is the pancreatic phase, and in the pancreatic phase, there is some hypoattenuation of some lesions. And that might help you sometimes discriminate it from the adenocarcinomas or lesions that can be there. And third is the portovenous phase. Can you just quickly tell us why do you need to have the portovenous phase?
One of them, who's I think maybe Mithun.
Oh, sir, portal venous phase we want because to know because most of the time the pancreatic lesions will be having some relation with the portal vein also, sir. We want to know any contour irregularities there in the portal vein, any thrombosis in the portal vein, and whether any area of narrowing of the portal vein, because that decides on our further treatment as well as surgical options, sir.
Yeah, that is good. And importantly, not only about the anatomy of the portal vein or the thrombosis, very importantly, it also gives you a better delineation of the hepatic metastasis if there are any.
Okay.
It is, if you ask me, one of the most important reasons why you need the portal venous phase, it is basically to identify the hepatic mets in a case of pancreatic as well.
Yes, sir.
Why endoscopic ultrasound was not considered? The reason is endoscopic ultrasound would not only have given, when you have an ultrasound was suspicious, endoscopic ultrasound would have given you a chance of both examining for any GI ulcers as well as getting a FNA at the same time. EUS, instead, when the upper GI endoscopy, when you know that ultrasound is showing a lesion in the pancreas, I, in your place, would have asked for an endoscopy and endoscopic ultrasound at the same time. It will clear your three problems. Ultrasound problem that you are saying of gas will be cleared, and endoscopic ultrasound is much more sensitive with a high frequency probe. This would have been one of the options, and you can do a FNA, fine needle aspiration, at the same time if you can see the lesion.
Yes, sir.
Okay, so I think that is one of the options which is there. I think, we'll come to that in a little later. I think we'll elaborate on that. This is a CT scan. Now, we have no, I can't give you all the faces and everything. I'm just running this, and then I'll show you the, report, because, but can you pick up something in this? I'll stop in the vital place. This is, what phase is this? Can you make out?
Arterial phase, sir.
Okay, arterial phase, fine. Dr. Kush, can you, now you take over, and if you see something in the CT scan, please point out to me. If you want me to stop somewhere.
So we can see, yeah, here only we can see. We can go back a little bit, sir.
Okay.
Yes, sir.
Mm-hmm.
So I think, yeah, so
what
this
I'm seeing here.
Celiac artery.
You want me to play it?
Yes, sir.
Okay. It's very difficult to show the, yeah.
Yes, so the structure that you showed was the SMA, sir. Sorry, celiac artery.
Okay, fine.
And this is the SMA vein, sir.
Yeah. I'll stop at this because anyway pancreas is over. Anything
Yes,
particularly have seen?
So there is a mass at the uncinate processor. We can, yeah.
Where?
Just scroll it a little, sir. So this is the D2, and then
yeah.
Further down.
Characteristics.
Yeah.
Anything you can make out?
As of now on these scans, sir, it looks like a heterogeneous enhancement, sir. I'm not pretty sure, but this is what it looks like right now. Heterogeneous enhancement in the arterial phase it's shown.
Okay. Dr. Randir, you want to add anything in this particular, because it's very difficult to make out on this scan. It is not, because it's a very small lesion. Do you want to add anything?
Sir, vascular contact is what we look for apart from that. So
no, I will go to that, what all things they have to see, but do you see any lesion? We have to ask them that question. Candidates.
I can see the lesion in the head and uncinate process.
Yeah, but it's not very well defined, I guess, right? So this is the thing. So I don't think we have to. But what the question which Dr. Randir was asking, Let me ask Kush.
Yes, sir.
What are the key things? Say there is a mass in the head of pancreas. So what are the key things that you're looking for in a CT scan when you see the mass? If as a surgeon, what are you looking for? Your radiologist has told you that there is no metastasis, there's nothing else, but you want to know, you have to operate tomorrow. If you have to, what would you look for in the CT scan?
Okay, sir. So I'll begin with, first of all, I would want to see the location, the size of the lesion, its relationship to the nearby structures. First, the main pancreatic duct, the CBD, the duodenum, then nearby, as in if we have any enlarged lymph nodes, vascular relationship with the supramesenteric vein or the supramesenteric artery. If at all we have any kind of abnormal arterial anatomy going to the liver, liver mets, and any peritoneal or ascites if we can address. These are the things I would be looking at.
See, in an exam,
yes, sir.
In an exam, usually a scan will be given to you to read.
Yes, sir.
So you need a system to read the scan. So that is what, sitting here, I would expect you to tell me, what all things you will start with. Like, in a plain CT, what will you look for? In a next, whichever phase, arterial phase, what would you look for? These are the things which you would expect to know. Do we, Dr. Bojwani, would you agree with that? That's the way we would expect in the exam.
Yeah, exactly. So you have to have a scheme of presentation when you present any imaging. So starting from 1, 2, 3, and that would usually begin with what kind of scan that you're looking at, what phase you are appreciating, and then going to the local lesion, that characteristics of the local lesion, and any evidence of metastasis or dissemination. And then, of course, after the local lesions, you go on to the vascular anatomy and the attributes that can help you identify the resectability or no resectability, and then going on to dissemination. That's the usual schema of presentation by any candidate for whatever imaging that you're looking at in whichever part of body actually.
And here I agree that it's difficult because I can only give you one skill, this one. So I have agreed in the beginning itself there is a deficiency. Now, so this is what the report says. There is a 30 by 30. Sorry, my mouse has stopped working for some reason. Okay. Okay. So there is an head and uncinate process pancreatic mass measuring about 30 by 30 into 50 millimeters. It abuts the duodenum with a loss of fat plane. Fat plane with SMA, portal vein, and celiac trunk is well preserved, and fat planes with SMV is ill-defined. However, no definite compression or thrombus noted. So now you have a patient with this report. What would you do, Dr. Mithun?
Sir, this lesion is enhancing, like in the arterial phase, it looks enhancing. Sir, okay, sir. So usually pancreatic adenocarcinomas are hypo-enhancing. When we get a hyper-enhancing lesion in triple phase CT in the arterial phase, we should definitely suspect a neuroendocrine tumor, sir. So when we have a suspicion of a neuroendocrine tumor versus adenocarcinoma, it is always better to go ahead with a tissue diagnosis. So I would like to get an EUS and EUS gated FNA if possible from the mass lesion, sir, in this patient.
Dr. Kush, would you do something different?
My answer would be the same only, but my reasoning would be a little different, sir, because here we have an SMV, we have a doubtful involvement of these SMV. This makes it or puts it in a borderline category, if at all. And we still want to keep the diagnosis of adenocarcinoma and neuroendocrine as my DDs as of now. And if it is borderline, I would be inclined more towards getting an FNA done before, and so that I can talk in a better fashion with my patient and give him the better options.
Okay. Now, in this kind of a scenario, would you take this patient directly for surgery? If yes, why? If not, why? Kush. It's to Dr. Kush, yeah.
I
couldn't hear you. Sorry.
So I would be inclined to take the patient for surgery, sir.
Wouldn't be or would be? Sorry.
Would be.
Would be. Okay.
Yes, sir. Because on seeing the CT pattern, where it's showing some kind of a heterogeneous enhancement, sir. And I would explain to the patient regarding the possibilities.
Dr.
So urgent in surgery.
So we'll ask the candidates, we'll go to, I'll ask the experts after that. Mithun?
Sir, I wouldn't be taking the patient for surgery because that enhancement pattern is not typical of an adenocarcinoma. Even if it is an adenocarcinoma, that SME involvement, I won't take it like a borderline no problem, sir. It looked in
Just
the
tell me, both of you, just tell me, when do you really take a patient without a histopathological diagnosis for surgery? We talk about this, the very important clinical point is there in this case, which I would not consider. What is the important clinical point here, which tells you that you should have an histological diagnosis here?
The vascular involvement. The vascular involvement, the vein involvement.
No, not necessarily. Is there jaundice here?
No, sir.
So you cannot mix up the management of obstructive jaundice with this. That's why I said this may not be your may not be your examination scenario. But when there is no jaundice, when there is a very small head mass, to give you an idea of what, and there is a borderline operability you're talking about, you need to go for a biopsy in this scenario. Dr. Bhojwani, would you agree with me or?
Yeah, I do agree with you. But Mithun and Kush, try to understand when the examiner is posing questions to you. Dr. Sandeep is purposely giving you a room to think about this patient holistically and not with this prefixed mindset that this is an NET because this is a class on NET. This is the patient who does not have jaundice. We have seen a lesion. You yourself mentioned that it is a heterogeneous lesion. It is not uniformly hyper-enhancing. So I think it is important for us to keep in consideration not only adenocarcinoma, but also lymphoma, which can be there. That is one. Secondly, we know that NETs can be familial. There are genetic syndromes. We have not taken any history about the family members. We have not palpated her parathyroid. We have not done any biochemistry. You do not have CA19-9. You do not have serum calcium. You do not have serum parathormone. You do not have serum chromogranin. And I don't know if other markers are present in your hospital or in your environment. So all of these things, they come first much before you embark on this decision whether you are going to go ahead and operate or not.
Yeah.
NETs are known to be multifocal. If you do not have a satisfactory scan, you need another scan, maybe another scan, and then second and the third scan. So please don't jump onto the diagnosis of surgical resectability or no resectability. We are still at least 2 or 3 steps away from that decision-making pedestal, I think.
There are times when, in a pancreatic mass, can you think of a non-malignant, non-oncogenic, non-neoplastic mass-forming lesions? You can think of anything? Patients do present with, they're non-neoplastic masses. Can you think of something? Mithun, Dr. Mithun, sorry.
Sir, cystic neoplasms can happen, sir. Like
non-neoplastic, I said.
Sir,
non-neoplastic lesions. We do see it clinically.
Sir.
Anything, Dr. Kush?
No, sir. Doesn't cross my mind.
Autoimmune pancreatitis? Dr. Bhojwani, I think in practice we do
autoimmune pancreatitis, tuberculosis. I get to see at least about 1 pancreatic cox every year. And all the same, maybe 1 or 2 autoimmune pancreatitis every year. So you need to rule them out. You need to have that history. You need to be sure about the morphology, and then based on the morphology, trying to corroborate with the symptomatology and further investigations. So there's a lot which needs to be decided upon when you come across a lesion in the pancreas.
So now we went ahead with US. I think Dr. Randir was asking about US at that time. We have a biopsy which suggests a well-differentiated NET. they did a biopsy, NET. What test do you want, further test do you want in this, Dr. Kush?
So I would like to.
Can a simple histopathology diagnose NET, or do you need any further tests?
So the IHC for synaptophysin, chromogranin, and the Ki67 index we need to grade the disease if it's well differentiated. And furthermore, would be an imaging we want to do.
So do you have a classification? Do you know what is the classification of neuroendocrine tumor, pancreas, anywhere, or pancreatic for that matter?
So the WHO classification 2017, where they've classified the neuroendocrine tumors into well differentiated and poorly differentiated.
You want to first tell me a clinical this one? You want to directly go to histological or immunohistochemical, or you want to tell me clinically how do you see a neuroendocrine tumor?
Functional and the non-functional.
Good. That's very important, because you are examining the patient. You need to know whether it's functional or non-functional. Then histological comes. So somebody has told you it is a well differentiated neuroendocrine tumor. First thing is for you is to see whether you have missed something functional. So how do you classify that? Functional, non-functional. Functional, what are the different types?
So non-functional pancreatic neuroendocrine tumors.
They're non-functional. What about functional?
Functionals can be gastrinoma, insulinoma, somatostatinoma, VIPoma. Then there are the rarer kind of varieties where are the ACTH-oma and the others.
Glucagonoma?
Glucagonoma also. Yeah, I missed that.
So, any particular questions on that from faculty, Dr. Randhir?
Which syndromes? Same as the syndromes and their functional neuroendocrine tumors and their syndromes.
So usually the functional neuroendocrine tumors are associated with MEN1 syndrome, the von Hippel-Lindau syndrome.
Functional neuroendocrine tumor causing syndrome, like
the MEN1 syndrome.
They are associated. Zollinger-Ellison and VIPoma insulinoma causes Ford syndrome. All these things. Okay, you are saying about hereditary conditions. Which hereditary malignancies are? Which hereditary syndromes are associated with neuroendocrine tumors?
MEN1 syndrome, the VHL, the von Hippel-Lindau syndrome, neurofibromatosis, and tuberous sclerosis. So these are the types which are the most commonly associated.
What is MEN4?
So MEN4 is categorized wherein we have tumors of MEN1 category, but we do not have a MEN1 mutation. Such patients tend to have mutation in the CDKN2A mutation, and the chromosome is chromosome 4 mutation. They have mutation similar to the MEN1, but they do not have the MEN1 mutations.
Apart from that, they are associated with the tumors of the thyroid cancer, papillary thyroid cancer.
Yeah, yes, sir. Thyroid, adrenal, and renal. Yes, sir.
Okay.
So now you are going to ask for immunohistochemistry on this. So based on immunohistochemistry, they confirm that it's a neuroendocrine tumor. I don't know whether I put it. So now interpret this for me.
So this is for?
This is IHC report. So what is you can see the slide, right?
Yes, sir. So
I'll ask Dr. Mithun to interpret this one.
Sir, so chromogranin and synaptophysin is positive, sir. So it's a neuroendocrine tumor. Okay. And Ki67 index of 3 means that it is of intermediate grade. So is it intermediate grade, sir?
Is it intermediate?
Yes.
So in pancreatic neuroendocrines, they consider till 5 also, but as of now on the till 5% is low grade. But as of now, WHO classification, it is intermediate.
Dr. Bojwani?
Yeah, so, there is a kind of difference in terminology by various organizations.
Yeah.
So low, intermediate, and high, it's also, labeled as grade 1, 2, and 3,
Yes,
so it is, let's go by grade 1, 2, and 3 rather than labeling them as low, intermediate, and high, because that creates a bit of confusion. And then, of course, neuroendocrine carcinomas are separate, which are grade 3 but poorly differentiated. So an important thing is,
do they know about how to differentiate between neuroendocrine carcinoma and the grade 3 neuroendocrine tumor? What is the difference? Dr. Mithun?
Sir, neuroendocrine cards, the cellular structure will be more like mature cells in a grade 3 well differentiated neuroendocrine.
First of all, the first criteria, Ki67, start from that.
Ki67 will be more than 20%, sir, but it will be less than 50%, usually in a grade 3 neuroendocrine tumor. But in neuroendocrine carcinomas, usually we get a Ki67 index of more than 55%, sir, according to WHO, recent WHO classification. Ki67 will be more than 50%, sir, in neuroendocrine carcinomas.
Okay.
Well,
yeah,
just you are right, but that does not make it a carcinoma. Only if Ki67 is more than 50, that does not make it a carcinoma.
It should have, it should have features of either local infiltration, either nodal metastasis, or a distant metastasis to label it as a neuroendocrine carcinoma.
Yeah. So no, and also, of course, the poorly differentiated. It can be well differentiated also with all those features being there. What you need to know is whether it is well differentiated or poorly differentiated.
Okay, sir. Okay.
Because that will have a bearing. That will have a bearing on the serum markers. That will have a bearing on how it shows you on a scan, a particularly molecular scan. So that is how you label them as poorly differentiated. And it has been shown that grade 3 NETs have a different prognosis as compared to neuroendocrine carcinomas.
Yes,
so Ki67 may be the same, but the number of mitosis may also be the same, but it is poorly differentiated. That's important.
yes, sir.
What is menin?
So menin is a mixed neuroendocrine and non-neuroendocrine tumor, sir, in which we find neuroendocrine component along with other components like adenocarcinoma, squamous cell carcinoma, mixed tumors, basically. So a poorly differentiated variant.
No, there's a lot of difference between NEC and menin. Menin, here, if it is more than 30% of the cells are neuroendocrine differentiation, you call it as menin.
Okay.
Otherwise, you call it as adenocarcinoma with neuroendocrine differentiation.
So after this, what is the next investigation you want? Or what do you want to do next? Forget investigation. You have this a well differentiated neuroendocrine tumor of pancreas, head of pancreas, unseen necrosis. Now, what next? Would you want to do any investigations, or you want to go for surgery? What is your next plan?
Sir, in the staging process of neuroendocrine tumor, always include a serotonin receptor study also, sir.
Not serotonin receptor, it is somatostatin receptor.
Somatostatin receptor study also, sir. SRS, and the recent guidelines say we will rarely go for a gallium dotatate PET CT in order to stage the disease, sir.
What is gallium, dota, and tate?
Sir, gallium is that radionuclide, sir, and tate is that octreotate compound, and dota is the I actually don't know, sir. What is dota?
Kush, do you know what dota is?
So dota is the chelator or the linker between the gallium, which is going to be seen on the scan, and the tate is the peptide that is going to attach to the serotonin somatostatin receptor. So it is the linker or the not sure of the word.
BFC, bifunctional chelate. One side it binds to the peptide, the other side it binds to the metal. So these are BFC. And so gallium is a positron emitter, dota is a BFC, and tate is a peptide.
In this case, you'll consider the dota. Say if it was intermediate grade, it was somewhere around 7. What would be your choice of PET? If you're doing PET CT, what would be your choice? Kush, I think you can take.
So I would have gone with the gallium dotatate scan, sir.
Alone?
And it's an intermediate grade. I would consider adding a dual tracer as in an FDG PET also to include it.
For what benefit?
So intermediate and high grade neuroendocrine tumors, they can have a differentiation, as in a poor differentiation. And in those cases, the serotonin uptake is not that much. In that will be picked up in a FDG PET.
Serotonin? Both of you are set to
Somatostatin.
serotonin.
Somatostatin. I keep
Okay.
somatostatin. Yeah. So, or if a tumor could have a poor differentiation, in that cases, the FDG PET will be the one that will be picking up the metastasis, rather a somatostatin receptor scan.
Okay. So, Dr. Randir, would you do dual scan, or generally what would you do? Not in this case, intermediate. I'm just taking little tangentially.
Sir, it depends on if it is a still surgically resectable. I will go only with gallium dotatate scan alone, and I would investigate for calcium, which is calcium, and I would look for the adrenals in the CT. And the third thing is calcium should also be done along with PTH.
Okay. I think we could have asked them that question. What else, before surgery, what you want to do? I think you gave away the answers already. Right. So this is what is the Dotonac PET CT gallium Dotonac. So you can see it's a similar findings, and the SUV uptake is 93.2. What do you understand by SUV, Dr. Kush?
SUV uptake, as in the tracer is so the receptor concentration and the uptake of the gallium is higher in that section.
No, I am just asking about SUV. I'm not asking you what is the meaning of
standard
SUV?
uptake value is the full form of SUV.
Okay, how is it calculated?
So I will not know the details of it, but every positron, every gallium atom that's going to attach to the receptor, it is going to emit some positrons, which will be detected by the scan. And
Dr. Randir, I think you can just take
it. Is not standard uptake value, it is standardized uptake value. If you give something and if it distributes uniformly to the body, what will be the value and versus this value? So it depends on the distribution of the tracer. What nuclear medicine people do as such is evaluate for biodistribution. We check how the tracer is going into the body. The distribution is 93 times more than what it would have been if it would have been distributed uniformly. I said in a layman terms, I can give you a formula which will be of no use for you.
So, when would you consider an investigation like this? Whenever you ask for a next investigation, you have any idea, you have a thought process as to, how often it will change your, next line of treatment. So a PET CT, if you're doing it, it should change at least in 20% of the patients, it should change the management. So otherwise the investigation is of no value. So here, anything that particularly you want to see, you are seeing the mass, you are seeing all the fat planes with SMA portal vein and cystic celiac trunk is well preserved. Fat planes with SME is ill-defined still. However, no definite compression or thrombus. Now, there's nothing else really of significance here. So with this report, what would be your next thought? Dr. Kush, you are talking, right? Yeah.
So on seeing these scan and the reports, this looks like a local, as in just the vascular involvement is there with the uncinate process mass, which can be taken out, and it's a well-differentiated neuroendocrine tumor. So with well-differentiated neuroendocrine tumors, if we are able to go ahead with an R0 resection or even R1 resection or an upfront surgery, these patients tend to have a good prognosis and a survival. So I would have a discussion with the patient, and I would plan for a upfront surgery in this patient, because it does not have any other liver or extra tumors.
Okay. Any options to keep the patient on surveillance?
So
you will say, I'm a surgeon and operate.
Especially in this patient, you're asking option of surveillance, or
no, any patient? Yeah. How will you decide that your patient? If you ask me, yeah, how will you decide that you want to keep this patient on surveillance, you don't want to operate? How will you take that decision?
Yes, sir. So usually in incidentally detected masses or patients who do not have any symptoms because of the functional tumor or any mass effect of the tumor, usually in patients who have very low grade or low grade neuroendocrine tumors, and maybe in the extremes of the ages or comorbidities of the patient which prohibit any surgical intervention.
Size criteria, anything for?
So in pancreatic pancreatic masses less than 2 centimeter, which are away from the main pancreatic duct, such patients I would give them the option of keeping them under surveillance and then take it on from there. Sir.
Right. Dr. Bojwani, you want to add anything? I think he has put everything almost.
Yeah. I think he has mentioned it very well.
Yeah. So, so in this case, Dr. Mithun, what is your plan? If you want, you agree with surgery, or what is your thought?
Yes, sir. I would agree with surgery because
Okay, what surgery?
Sir,
we have taken quite a long time for the single case. I thought it's going well, so let me go on. I hope organizers also agree.
sir, surgery, the ideal surgery for this case will be a pancreatic duodenectomy, sir, because it is a lesion involving the head and uncinate pores of the pancreas. Sir. So I will be taking the patient for a Whipple's procedure, pancreatic duodenectomy. Yes, sir.
Okay. So before you take this patient,
Yes, sir.
What all things you have confirmed, because it's a neuroendocrine tumor. It's already been discussed partly, but what are all the things which you want to confirm here?
From
the patient does not have.
Yes, from the history, sir, the patient doesn't have any symptomatology of a functioning pancreatic neuroendocrine tumor. He
Apart
doesn't.
from pancreas, outside of pancreas, which are tumors you want to confirm that this patient does not have?
Yes, sir. I would like to rule out the tumors associated with MEN1, like hyperparathyroid tumors, and I would like to rule out any pituitary tumors also, sir. For that, I will be doing a serum calcium, serum PTH, as well as a serum prolactin levels, so that the components of MEN1 syndrome can be ruled out, sir.
Okay. Okay. So, Dr. Ranbir, anything else you would like to point out in this?
Will you do cholecystectomy or not?
No, that's surgical steps. Okay. We will end up doing that because as a part of Whipple's, we have to do it. So it's out of question. Okay.
No, why even if it is not Whipple's, if you have it a body and tail, will you do a cholecystectomy or not? You have opened the abdomen. It's a neuroendocrine tumor, intermediate grade. Will you do a cholecystectomy or not? What is the rationale if you do? What is the rationale if you don't do?
Dr. Mithun.
Sir, cholecystectomy in the patient has got a chance of multifocal, sir. I don't know exactly. So
we will do, sir.
Why?
So in an intermediate grade, or this patient may at a later stage land up into or will need or might need a somatostatin as a adjuvant therapy or a therapy. Somatostatin therapy in a later stage will predispose the patient for gallstones, and if it opening the abdomen, might as well take out the gallbladder. That will help the patient later on. We might not.
Any patient which, if you feel that he may need sandostatin, octreotide, whatever, somatostatin cannot survive in the blood for more than few seconds. So you use a long-acting analogs, that is octreotide LAR, whom you feel he may need them. You should do a cholecystectomy when you are opening the abdomen, because it will prevent gallstone formation and the patient will have biliary dyskinesia and pain. So cholecystectomy should be considered when you are opening an abdomen in a planned mode. If you are doing on an emergency basis, I don't know, that is your surgical principle. But when you are planning for it, please plan for cholecystectomy in any case of neuroendocrine tumor. And coming to the SUV part, I forgot to mention, don't go by SUVs, go by scoring system. There is something called Krennic score. Krennic score, any of the examinees know what is Krennic score?
Yes, sir.
Yeah.
Krennic score is basically we compare the uptake of the lesion to the liver. So it has grading from 1 to 3, 4, wherein the uptake of the lesion is less than liver, then it's 1. If it's equal to the liver, it's 2. If it's more than liver, then it's 3, and if it's more than spleen, it's 4.
Good. The Good answer. And the clinic score is what you should consider as a clinician. The SUV can vary. If you just do extra visitation, the SUV can change. So you always look at clinic score. The grade 3 and grade 4 clinics are well differentiated entities.
So as a surgeon, what problems do you anticipate in this particular case? Dr. Mithun?
Sir, in this patient, sir, the CT is showing an area of loss of fat plane with the superior mesenteric vein, sir. So that area is going to be a concern. So we have to intraoperatively only we can judge whether it is a true infiltration of the tumor or whether it is just an abutment of the vein, sir.
Okay,
because it is not
next. What next?
Sir, otherwise, I will go for a if it is a lesion which is not infiltrating the vein, we can go for a standard Whipple's procedure, sir, in this patient.
Dr. Kush, anything other than that, whatever Mithun has already told, anything that you want to point out? As a surgeon, I'm asking, it's a very specific question.
So I would preoperatively just want to review the scan with the radiologist, look for any abnormal vascular anatomy.
All that is done, you have seen.
And I would want to keep a vascular surgeon or in
you did that. What else would you like to think of as a problem? I'm anticipating a problem I'm talking about. Something about the pancreatic duct you want to elaborate? Do you want to think of something? Because what do you expect in the pancreas here?
Pancreas should be soft and friable, soft, and the main pancreatic duct should be smaller as in.
So are you scared? Are you scared?
I would not be scared, but I would.
Dr. Bojwani will say, what?
No, I'm interested to know, why do you think that the pancreas would be soft? What makes you think so?
2 reasons. She's not had any history of any pancreatitis or any feature suggestive of that. Secondly, the scan does not say that the main pancreatic duct is dilated. It's not evident also. And we've not given any kind of neoadjuvant also of any form. Less chances of the pancreas to be as in hard or features of pancreatitis, sir. It should be soft, sir. I'm not sure, but this is what I think, sir.
Do you think that the inherent property of causing fibrosis by NETs affects the remaining pancreas?
Yes, sir. That also affects. Yeah.
So adjacent pancreas might actually be slightly fibrotic.
Yes, sir.
Adjacent, not the entire pancreas. There is no back pressure effect here. There's no pancreatitis here, but adjacent pancreas might actually be. And that is why, I mean, maybe not about the Whipple's, but when you're considering other procedures, you might, when you do not, and as it is, you know, in NETs, you do not believe in taking very big margins because it does not make a difference. You might find a good firm pancreas there. You might. Although that's not, you know, evidenced in the literature. That's just my impression. That's it.
If it is the case of MEN1 and the same tumor is there, what else you will do during surgery?
Chances of multifocality are there, sir. We might miss a few tumors. Preoperatively, if we have done an endoscopic ultrasound, I would ask the radiologist to see if there's anything else, if he's seeing any lesion else. Otherwise, intraoperatively, also I would keep an intraoperative ultrasound available, and bimanually also we can palpate and see if we are missing any lesions which are not there on the scan.
And the answer is intraoperative ultrasound. I wanted to ask.
Yeah, it's intraoperative ultrasound. Bimanual palpation is of no use if you're trying to do it on table, because see, neuroendocrine tumors which are functional will be very, very small in nature. So non-functionals will grow, but these functional tumors can be a big problem as you go on. So,
but just to emphasize here, Mithun, that you know, as Dr. Sandeep has absolutely emphasized upon it, intraoperative ultrasound might be handy, but you should make it a point that you do not mobilize the remaining pancreas in order to palpate the remaining lesions bimanually. It adds to morbidity, and even the guidelines mention that it should not be performed.
So shall we move to the next case? We have very less time actually. We have had very Dr. Srijan, what do we do?
Sir, we'll continue. We have another 15 minutes. So either this case or the next case, whichever one case, I think we should finish, sir. Another one.
No, this is also a good case. We'll do this. So the second case is a 52-year-old male with complaints of epigastric pain radiating to back. Ultrasound, again, it is a similar thing. We came with an ultrasound which shows a mass lesion in the body of pancreas, and again blood parameters are normal. So I think the things will be similar to what you have said, so I don't want to go into that now. I'm directly going to the CT scan. I want you to read the see the CT scan and tell me what you find. We'll make it like a short case. Tell me if you want me to stop or run it again. I know it is difficult. It's not the ideal way to do this, but I'm playing it again because. So, Dr. Mithun.
Yes, sir. As I say, contrast enhanced CT is in the portal. It's in the venous space, sir. And I could see an enhancement in the segment 4 region, sir. But can you please go once again to the pancreatic region, sir?
Yeah, this is in not
segment
in
4. Can stop?
Yeah, it is not at all phased properly, frankly.
Oh, what lesions give you a suspicion of neuroendocrine tumor metastasis in liver?
Sir, just like the primary hyper-enhancing in the arterial phase, a hyper-enhancing lesion along with a hyper-enhancing lesion in the pancreas would always suspect a metastatic disease in the liver, sir. In this patient, I could see a hyper-enhancing focus in the region of head and body region, sir, of the pancreas also.
How do you differentiate head or body?
Sir, SMV, any lesion towards the left side of superior mesenteric vessels, it will be the body, the region of superior mesenteric vessels.
Clearly in the body then.
Yes, sir.
Clearly
the body, yes, sir. It's towards the left side.
Yeah.
That's it. I am looking
if
at
it is left of SMV, it is body. If it is right of SMV, it is head. There will be no confusion.
Yes, sir. It's in the body.
And hypervascular metastasis. What is the DD? And just within seconds, you say me, what are the DD for hypervascular metastasis?
Commonest will be renal cell carcinoma. Second will be breast, then thyroid, etc.
Most of the time, endocrine and renal malignancies and neuroendocrine tumors and melanoma. These are the only 4 DDs which are common. Breast will produce hypovascular. Very rarely it produces hypovascular metastasis. Colon will produce hypovascular metastasis.
Yes, sir. Yes, sir.
So there is a lesion in the body of the pancreas here. What did we? Yeah. So this is how the report reads. In fact, there are a few things here which you have to see, which I think was difficult to see in the video. I agree, it's not easy to see it. So see, there is a small lesion in the segment 4 of liver, which is 2.7 centimeters. Moderately, lesion shows mild to moderate enhancement on post contrast study, and rest of liver parenchyma is normal. We'll go step by step here. For this liver lesion, what do you want to do when you see a liver lesion like this on a CT scan? What is your next step to confirm what this is? This is Mithun.
Sir, I would definitely like to go with an ultrasound guided FNAC from the lesion to rule out any metastatic disease, sir.
Okay, FNA or true-cut biopsy. Would you do, Dr. Kush, anything particular?
Ultrasound guided or ultrasound guided can be done on a segment 4 lesion, sir.
Why not an MRI to just characterize it further? Would you like to do it?
Yes, sir. It says a poorly marginated hypodense lesion.
Where does MRI help you?
MRI is better for a resolution for liver mets, and wherein dilemma is there regarding the type of a lesion on a CT scan. So it acts as a problem solver for a CT image.
Dr. Randir, you want to?
No, it's not cost effective to do so.
No,
It's not cost effective. First, say what is the primary pancreatic lesion. If you are suspecting a neuroendocrine tumor, I would prefer to go gallium dotanol PET CT or SSTR PET CT, what we call. If you are thinking in terms of proven of neuroendocrine.
Yeah, we don't have a suspicion.
So that's why I would try to get a biopsy of the primary first.
From imaging, I wanted to go into the pancreatic part of this, in the imaging, where it is telling, you have poorly marginated focal lesion seen in the body of the pancreas with associated lobulated contour, and lesion is seen along the superior surface, measures about 2.8 into 3.9 centimeters. Pancreatic duct is compressed and appears prominent. Lesion is hypodense and shows moderate heterogeneous enhancement on post-contrast study. Rest of the pancreas appears normal, whatever is left behind. So, under these circumstances, a patient, remember the history, patient came with the pain, back pain, radiation is there. Would you do any further investigations? What is your opinion on this? Kush, Dr. Kush.
The liver lesion I would want to characterize.
Okay, you did that already. I took you there. That is done. That biopsy came. That is negative.
Okay. And
Dr. Mithun, would you do anything?
I want to get a CA99 value also, sir, because it could be a pancreatic malignancy with liver metastasis. And after
liver metastasis, okay.
Sir, I would like. And then, because the lesion is not classical of a neuroendocrine tumor or a pancreatic adenocarcinoma, I would like to go for again an ultrasound guided biopsy of the mass lesion, sir.
Yeah. When you look at this, do you see any cystic component or anything? You have a differential diagnosis here. So I want to take you back to this. I want to know what is your differential diagnosis.
Sir, it could be, sir, there are lobulations also, sir. So it could be a pancreatic adenocarcinoma. It could be a pancreatic cystic neoplasms like fusion cystadenoma or even an IPMN. And because it is having a heterogeneous enhancement, it could be a neuroendocrine tumor also, sir. So I would definitely like to get a biopsy from the mass lesion in this case.
Okay, Dr. Bojwani, would you do a biopsy, or you don't want to waste time on this?
Well, there are several issues. One is, as you rightly said, Mithun, that this is neither characteristic of an NET nor characteristic of an adenocarcinoma, but there is a doubtful lesion in the liver. Okay, doubtful. The sonography has been done, but unfortunately that has not picked up anything, but that lesion is there. I would like to actually go, in my opinion, I would like to go with further imaging to have some more information, and then and have molecular markers, and then decide upon it. Importantly, it is not always neither safe, not possible to have an EUS guided FNAC from these lesions which are in the distal body and tail. And trying to do a percutaneous ultrasound guided FNAC, you understand, has its own risks and may not actually have a good yield also. And you have the pancreatic duct, which is slightly dilated, which is slightly prominent. So I think, and a good part is that you are not getting to see any lymph nodes around, at least on this CT scan. Okay. So I think there are so many things which need to get settled, and I would, in my own preference, order at least one more study, which Dr. Randhir has very rightly put forward as the SST scan, plus, and maybe a dual scan, SST plus FDG PET.
But at this stage, we don't know whether it's new. Yeah. So the dual marker you would prefer. Dr. Bojwani, you said dual
FDG and SSTR PET CT. The other way of going is get an ultrasound guided FNAC of the liver lesion, and if it is feasible, accessible according to the sonologist, get a FNAC If it's suggestive of NET, you can go for SSTR PET-CT. If it is suggestive of adeno, you can go for FDG PET-CT.
Yeah, but we are taking it for granted that the liver lesion hasn't shown anything, as already Dr. Sandeep has mentioned.
Yeah.
If that had shown something, that would have settled the diagnosis anyways.
Yeah.
So that is negative. So, but another thing about this particular thing, if you see this here, there is a thrombosis within the splenic vein. The entire splenic vein is thrombosed, and the thrombus is what have they said here? Splenic vein shows enhanced thrombus. So, how do you, when you see a splenic vein thrombosis or thrombosis in the portal system, what is the first thing what are the different types of thrombus that you can think of, Dr. Kush?
I can think of only two as of now. So bland thrombus, or it could be a tumor which is directly going inside, sir. So a tumor thrombus or a bland thrombus. Sir.
Okay, so both are possible here. So does it make a difference in your planning when you see a thrombus? What you want to do next? Because does your do you need something else when you do this, when there is a thrombus? Is there any test which will confirm that the vessel wall is not involved?
MRI is usually used for the vessel wall involvement, sir.
Okay, so what is that? How do you? Why does it do that? What is it that you are looking for in an MRI?
So in the MRI, the vessel wall will be infiltrated. I'm not sure, sir. What?
Vessel wall infiltration is what you are looking for, right? In an MRI will define it better because of the soft tissue delineation it gives you. So that's correct. Okay, so in a CT scan in a distal or body pancreas tumors, what are the key things you are looking for as far as vascularity is concerned? Blood vessels. What are the blood vessels you need to know before you go and do any planning?
So the relationship with the SMA, SMV, the celiac artery, and the portal vein, the diameter, and thrombus, and the collaterals, sir. Want to have a look at the collaterals, and at last, any abnormal vasculature of the hepatic system.
Okay, so that I think we have discussed, but I think you have covered all the things. Dr. Bojwani, anything else particularly you want from him on this?
No, I think we are going well.
Yeah. So what next is, I don't know what next year. After that, I didn't make, I think, because what would you do next for this patient? Means, what is your plan? You have done all the investigations. You have the dual. I don't think we did. We went ahead with a biopsy, which showed us neuroendocrine tumor. US guided biopsy we could manage. So neuroendocrine tumor is what they told us. So with the diagnosis of neuroendocrine tumor, what is your plan of management for this patient? Dr. Kush is answering. Yeah, go ahead.
So the primary lesion, along with
you have seen the vessels are which the vessels did you note, or you want to see it again?
Yes, sir. So the SMV is only in the splenic vein is the one that has got thrombus. The SMV, the portal vein are all normal. So everything got to the left of the SMV.
Okay.
So
right, you have seen that. So okay, what is your mode of what is your plan then?
So this looks like a resectable body of the pancreas or distal tail of the pancreas tumor with a splenic vein thrombosis and a liver lesion, which also looks on the scan to be operable. So with a neuroendocrine tumor as a diagnosis that we have, I would go for an upfront surgery. And
you want to know the grade of the tumor? You didn't ask me.
Sorry. Yeah, the grade of the tumor. So yeah. So
I was waiting for that question.
Yes.
So it's a grade 1 tumor. Go on. Okay.
So I would plan for a distal pancreatectomy with a splenectomy and a liver resection or liver metastasis.
Why splenectomy? Why not without splenectomy?
So splenic vein is already involved, and two reasons for the margin status also, as well as the lymph nodes we have to resect in the splenic area. Might as well take it out. The splenic vein is already thrombosed, and we've got effective immunization also, so we can take care of it later also. So all those reasons.
What does the evidence say? Is there a difference between splenectomy versus no splenectomy? Spleen preserving distal pancreatectomy versus splenectomy in distal pancreas?
I'm not aware of any level 1 evidence, but sir, for there is no much difference. As in, we can go ahead with the splenic preservation also. If lymph nodes and the margins we are able to get off without splenic. I'm not sure.
What is important?
Splenectomy, then you should have said first I'll vaccinate, then go for the surgery. You can't go directly for surgery. This is not an emergency. There is no emergency. NET grade 1. What is the emergency? If you can wait. If you're planning a splenectomy, why don't you subject them to the vaccination, then go for splenectomy? Before going for any heroic surgery, see what all preventive complications you can do. What all you can do to prevent complications. The patient is more chances of dying with sepsis than with neuroendocrine tumor.
Yes, sir.
I have a more conservative approach. I would have said, why not do active surveillance or give a octreotide, long-acting octreotide?
Would you agree, Dr. Kush? Is there a reason which you're thinking will go for surgery only, other than you being a surgeon?
It's a resectable tumor as of now, sir, and we have a splenic vein thrombosis, which might later on go on to the other part and maybe lead up to portal hypertension, which is dreadful for the patient at a later stage. So might as well tackle it at right now, where we can get an R0 resection for all practical purposes.
Justifiable. You're right.
So what's going to be your strategy regarding the nodal resection?
So this will include a lymph node dissection of the celiac along the celiac artery, splenic artery, the SMV, the hepatoduodenal ligament, and the common hepatic artery, sir.
Why hepatoduodenal ligament?
That's what
we have got a lymph node metastasis, sir. That's why I wanted to clear that off.
In the hepatoduodenal?
We have a liver metastasis. I would want to clear that also. Although for body and tail, we don't need to. For body and tail, we don't need to address the hepatoduodenal. But
see, now you are getting into a territory where you are not supposed to. Now liver metastasis, you are getting into liver metastasis now. So that's a completely different chapter. You can.
Another thing is, when you are saying a liver metastasis, when you are going for a big surgery, first, did you confirm is it solitary liver metastasis? Is CECT sensitive or SSTR PET-CT sensitive?
For a well-differentiated neuroendocrine, the SSTR is mostly.
So before going for any metastatectomy and a major surgery, always rule out that is the only metastasis present. Attempt to do a R0 surgery when not only if your aim and you wish and you get R0 resection, especially in low-grade tumor.
Yes, sir.
Yeah, Mithun, I would have said that since we are dealing with, of course, there are no guidelines on that, but regional nodal dissection is recommended for all NETs. For this big an NET, also it will be recommended. By and large, at the moment, as per the literature, we will go ahead with the plan, which is similar to ductal adenocarcinoma. And I think you should have said a kind of a RAMS procedure would have been indicated.
What is your approach in these cases? Would you do, Dr. Kush, what is your approach? You want to do, any name procedures for distal pancreatectomy? You want to name anything?
One procedure which sir has mentioned, the RAMS procedure, sir.
Okay. Then what else? I'm just asking. These are
for body tumors. One Appleby, I am aware, but
Appleby. Okay, what is it for?
I'm not totally sure, but usually for tumors of the body of the pancreas which have a celiac artery involvement, in such tumors we remove the body and try to preserve the head and the tail. And preserve the head.
You always preserve. What do you remove? What do you like it? What is it called?
The celiac artery is removed, sir, and the arterial supply in that case is from the gastroduodenal, but beyond that I'm not sure, sir.
From the gastroduodenal. Okay. Yeah. So You want to, Dr. Mithun, you know anything better in that?
In that
Not-
arcade, that arcade we preserve, sir, so that the vascularity from SMA to the hepatic artery will be maintained through
Correct.
the gastroduodenal arcade and
Yeah,
superior
it's
inferior
very
pancreas.
important that on table usually you have to clamp and see whether that works, that anastomosis works, or it is in a working anastomosis before. So nowadays, is there any technology that you use to confirm that? Is there anything on table that you can do?
ICG can be used for, sir.
Okay, ICG.
What is carcinoid crisis, and how common you expect carcinoid crisis during intra-op, and how are you going to prepare for it? How are you going to prevent it? What is the investigation you forgot to say to look for carcinoid crisis? Any neuroendocrine tumor, you should have subjected the patient to echocardiography first.
Okay, sir. Okay, sir.
What do you see for in echocardiography? In a
The
metastatic pancreas.
The mitral valve and the tricuspid and the aortic valve, these are the ones that are involved. The right-sided heart is the one that is involved, sir.
But Kush, one thing I want to ask you here. See, when do you see carcinoid crisis? When does it happen?
So usually in the midgut tumors that we see, when we are talking about the GI tumors, it's the,
and the prerequisite usually is, will it, if the tumor is sitting there, functional, okay, fine. What else?
Functional tumors, usually midgut tumors with liver mets or ovarian or
why is liver met required?
So because usually when the serotonin goes to the liver, it gets metabolized in the liver. But in the metastasis, when you have a direct liver metastasis, they directly go to the systemic circulation, so they cause the carcinoid syndrome.
So that becomes essential component whenever there is any neuroendocrine tumor. It has to go into systemic circulation. Otherwise, you will never see a carcinoid crisis, right? So,
do you get to see carcinoid crisis with pancreatic NETs?
No, sir.
I think
it is rare. Don't say no. It is very rare. It has been reported, but I think it's just about maybe 2% or so.
Yeah, Dr. Nayak and examiners, I think we'll have to conclude our case discussion, and with your permission.
Thank you very much.
I think we'll take some comments from the examiners, starting with Dr. Nayak and then to Dr. Randeep, and then finally to Dr. Bhojwani, about how the students did and any tips for them. It's unlikely that they'll face this case in an exam, but if they do in their clinic, any short tips for them?
See, they, in fact, under the circumstances, I think they did well. They are prepared well for the, for this these cases. See, one scenario wherein this can come is the table viva, wherein there can be, when examiners can put up a CT scan, and typically this is where the questions will start. So this cannot be your exam case, long case or short case, because there's no symptom or signs to really go by. So I think considering all that, you did quite well. You have answered most of the questions that we put, and I think you have done quite good. Okay, so all the best for your exams.
Thank you.
Yeah.
Yeah, Dr. Randeep.
I'm not a surgeon, and I don't know how your exam goes, but what I will help you in guiding the clinical practice. Don't rush for surgery, especially in low-grade tumors. Wait, investigate, rule out all complications, which you rule out prevent all complications which can occur. And rare things are also common, rare things with minimal investigations. If you can rule out, then it is better. A vaccination, if you're going for splenectomy, ruling out echocardiography is mandatory before this thing, and use a more sensitive test when you are going for a heroic surgery. When you use a more specific search, if I would have said a CA breast, if you don't do PET CT also, I would have never questioned. That is because it is a superficial structure. But when you are going for a heroic surgery, you use the most sensitive test to detect metastasis, right? And these tumors, especially neuroendocrine tumors, they have familial thing. They have multiple syndromes like type 1, and some investigations have to be used in couple, like calcium with PTH. gastrin with the pH, like that. So I was the next case was about gastrinoma, but because of lack of time, we are restricting here. So pH should be interpreted. Gastrin should be always interpreted with pH. Calcium should always be interpreted with PTH should always be interpreted with calcium and albumin, and all these things. So I would say before going to a heroic surgery, please discuss with your imagiologist. But you both have done extremely well, and sorry if I was out of context in any time.
With that, we'll ask comments from Dr. Bhojwani and also request him to load up his screen, because this will be followed by the expert talk on the contemporary management and controversies in neuroendocrine tumors of pancreas. Over to you, Dr. Bhojwani. I request the other examiners to stay till the end, because we'll have a short Q&A following this.
Yeah, well, I must congratulate both the candidates. I'm sure they were better than what I could have been in my training days. The only difference is that these days, we have online setup of examination, which is slightly different rather than physical examination. And as Dr. Sandeep mentioned right in the beginning, it is high time for you guys to start thinking like a consultant. So, like, the last case that we had. So first thing that came to my mind from the first slide was that the patient had backache. And when you have a patient with pancreas, pancreatic lesion, and has backache, in the OPD, in the first visit, that creates an alarm in my mind. So those are the things that, as a consultant, you will have to pick up, because that will have a bearing on the final, your schema of investigation and methodology of treatment. These are small issues, but I'm sure all of you will try to absorb it with time as your experience grows. But all of you have done well. Both of you have done well. Congratulations.
Thanks.
Yes, sir.
So with that, if you allow me, I will get going with my presentation. Just please allow me.
Yes, sir. We are all yours.
Yeah. Just give me one moment. I'm trying to remove one window from the desktop, which I'm not able to at the moment. I don't know why. Can I stop sharing and then?
Yeah.
Okay.
No
okay.
problem, sir. Yeah, please.
No, I think I've been able to do it now. So is that visible now?
Yeah, not full screen yet.
Is that okay?
Yeah, there you go, sir. Right.
Okay, great. Let me just minimize at my end. I'm sorry, just give me some seconds. I'm not able to move the. Yeah, okay. Okay, so very good evening, and let me thank Dr. Rao and the office bearers of IASO to have invited me over for this particular very interesting examination pattern and the lecture. And I did enjoy the camaraderie with Dr. Sandeep and Dr. Randhir, and I'm sure in my own mind, I have been enlightened a little on my own understanding about NETs and particularly the investigational aspects as highlighted by the other two examiners. So trying to point out some important clinically relevant features about NETs of pancreas. It is, I think, it's a growing disease, it's a growing cancer. And I think the SEER database pointed it out that these are more prevalent than the hepatobiliary, esophageal, and pancreatic adenocarcinomas combined. Now, that might be a very startling fact that we tend to ignore at times. And it is also important for us to realize, as we used to probably study and think of these tumors as very indolent and rare, these are neither indolent nor rare. And at least about 50% of these neuroendocrine tumors, I'm not about pancreas, neuroendocrine tumors might display some kind of nodal metastasis at the time of presentation. And when it comes to pancreatic neuroendocrine tumors, approximately about 28 to about 80% of these, when you go to a specialist center, will show you some hepatic metastasis also. And that's the five-fold incidence that has been seen in the last 30 years about the neuroendocrine neoplasms and the pancreatic endocrine neoplasms in particular. But most of this incidence has actually been because more and more of these cases are getting picked up because of the imaging innovations that we have had and the molecular markers also that help us sometimes. So when it comes to managing pancreatic NETs, as we have discussed during the cases, it is important for us to understand the grade, the stage of the disease, and the underlying pathobiology of the neuroendocrine cell type, because many of these can be functional, and the direction of differentiation, because that has a bearing on the imaging workup and the treatment, surgical or non-surgical. It is important to realize that overall survival of pancreatic neuroendocrine tumors is about 3.6 years. For grade 1 and 2, median overall survival is 42 months or more. When the lesion is localized to the pancreas, it can go beyond 10 years, 12 years. With nodal involvement also, many patients will survive up to 7 to 8 years. And with metastasis also, many patients will survive for maybe up to 2-3 years. And this particular median survival has improved in the last almost about 10-15 years. And it is the best improvement has been seen in metastatic pancreatic neoplasms, which with the advent of various methods of imaging, localization, and treatments like PRRT. Now, this is the usual histological subtype, hormones, and the associated syndromes. And you can take a look at in any of the books which describes it. I'm not going into the details. But importantly, most of the pancreatic neoplasms, the NETs, are sporadic, but about 5% will be in association with some predisposition syndromes. And you have already mentioned during the examination syndromes like MEN1, von Hippel-Lindau, tuberous sclerosis, and neurofibromatosis. Now, importantly, because I am also in my practice now getting to see patients and families with MEN1 syndrome, in the last 5 years, I've seen 2 families like that. And it is important that gene identification can be there. Hyperparathyroidism has been discussed during the examination. Importantly, very importantly, if you come across a patient who has a MEN1 syndrome, it is invariably multifocal in the pancreas, and this fact must always be remembered in mind. I've recently had a female patient just about 2 weeks back who had an insulinoma, who had a parathyroid adenoma. Both were symptomatic. She had contrast-enhanced CT scan. She had a Dotanox scan. And just because we were trying to enucleate a tumor, or at least planning to enucleate from the tumor from the body, we did an MRCP to locate the pancreatic duct, and the MR showed another lesion in the head, which was not seen on the CT scan and which was not seen on the SST imaging also. So it does happen, but always bear in your mind that MEN1 syndrome patients, most of them will have a multifocal pancreatic neuroendocrine tumor, and 20 to 40% of these patients will also have pituitary tumors. And once you have these MEN1 patients, then it is important to do a germline mutation DNA test in the patient as well as the family members, the kindreds. And if you find and isolate, if you're able to identify a carrier, this carrier must undergo a screening program, and it might actually start at the age of 5 years itself. For example, you can start screening for serum insulin in case of doubt. Now, regarding the recent advancements, now we do not have a very kind of a very universal tumor marker for NETs. The available markers have their limitations. But this is how the science is progressing. And we now have the exome sequencing available. And it is possible that in the next 5 years, we might have these tests in our clinical armamentarium. Mutations in MEN1 are seen in 44%, but mutations are also seen in these two places of telomeres of DAXX and ATRX. And it has been shown that if these two genes are lost, then these patients, they have a higher tumor grade, they have a higher rate of nodal disease, and they have a higher incidence of distant metastasis. Tumor microenvironment has also been identified, and it is being used to devise tests which can help us in identifying the tumor biology and deciding treatments thereof. These tumors, we know, they secrete proangiogenic factors, and therefore they are very enhancing on the scans, on contrast agents. They create a fibrosis, and we have discussed that during the examination, and they have a slightly cold immune environment as opposed to the ductal adenocarcinoma, which imposes a very strong immune reaction within the pancreas. And these have some imagings on the morphological differentiation on various scans and MRIs. We have discussed this already during the first case regarding the tumor grading, but as we emphasized there also, grade 3 NET has to be differentiated from grade 3 neuroendocrine carcinoma, which is poorly differentiated because the prognosis differs. I'm not going to the detail of the tumor staging. It is there, and I'm sure we can look it up in any of the articles or the books. When it comes to biochemical investigations, chromogranin A is a very non-specific test. It has a limited sensitivity and specificity, particularly for pancreatic tumors. There are drug interferences, like patients on PPIs will show a false positive high levels of chromogranin. And patients who are on dialysis or have renal insufficiency also will show higher levels of chromogranin A. The promise has come with any test. I haven't done it on any of these patients, and I'm actually not sure if it is available in India. But any test is a multi-gene expression-based mRNA assay. It has a very high sensitivity and specificity, more than 95%. The values are standardized, reproducible, and are not influenced by age, gender, ethnicity, fasting, or acid suppressive medication. And there have been 2 studies, independent studies, which have shown that the diagnostic accuracy might lie somewhere between 95 to 100%. And if the levels are more than 80, this is supposed to be much more accurate than serum chromogranin A as a prognostic marker. So I think there is some promise in any test. Chromogranin rates less for pancreatic neuroendocrine tumors, and the ongoing research is going in the direction of miRNA biomarkers and CTCs and metabolic profiling. I'm not going to discuss the details. Particularly for pancreatic NETs, metabolic profiling may not have all that much of an application. It is like metabolites of 5-HIAA in urine, which get picked up and tend to classify the tumors. But for other neuroendocrine tumors, it might have an application. So as I mentioned, the prognostic utility, at least at this point of time, to the best of my understanding and awareness, probably we just have about chromogranin A. And of course, for non-pancreatic neuroendocrine tumors, we have urinary 5-HIAA. But the best prognostication can be done with the tumor grade that we obtain pre-op or maybe post-op after resection. These are the biomarkers which have been suggested in various studies. And I would like to once again point out the NE test, which has a good promise. And particularly in pancreatic neuroendocrine tumors, you might have the pancreatic polypeptide, which can help. But I've just mentioned the various percentages for diagnostic accuracy and prognostic significance for various biomarkers that we have. So when it comes to imaging that we have discussed partly during our, the examination part, there are, of course, 2 types of morphologic imaging and the molecular imaging. Now, when it comes to morphologic imaging, when we do a pancreatic protocol CT, we get to see very highly vascularized and enhancement during the arterial phase with these lesions. The MRI, multiple sequences should be done. because basically what you have to have a T1 and T2 weighted images and also diffusion weighted images, which will give you various characteristics. And MR is definitely better than a CT scan in terms of picking up and characterizing the liver lesions, but it is less sensitive than a gallium's DOTA scan. So when it comes to sensitivity, MR is more sensitive, but CT is more specific when it comes to pancreas. But very importantly, and this study was published in 2010 in Annals of Surgery, which showed that 50% of these lesions are not detected by imaging, but were picked up on thin slicing. So even at this point of time in 2022, it is possible that we are missing significant number of these lesions which might be existing in pancreas, but are not picked up by any of the methods that we are using or are available to us. And it is possible that with the advent and improvement in technology, we might be picking up more and more of these lesions. And therefore, we get to see sometimes florid liver lesions, which exhibit neuroendocrine morphology and histology, but we are not able to localize the primary. For all practical purposes, as was discussed in the first case, a combination of a good contrast enhanced CT scan by the pancreatic protocol and EUS may reach 100% of diagnostic accuracy, and particularly for the head part. When it comes to deciding upon the biopsy or the histopathological availability, we need it for grading. We need to identify if the patient has multifocal disease in suspicious lesions. If the imaging is not very accurate, or you can say very equivocal, you might need a histopathological confirmation, and you might need EUS FNAC. And it does help in forming a surgical strategy. For metastatic disease, if you are going on with the surgical resection, like the patient which was there in the case 2, I think it will be important for us to have the grading, and therefore we must attempt to have the tissue either from the liver or from the pancreas, from wherever possible, with whatever risk-free or minimum risk methodology as we discussed during the exam. Heterogeneity does exist in the specimen, so it is possible that if you take FNAC or preferably or FNAB, the biopsy, in different places, the tumor might have a different grade. At one place, it might appear grade 1. At the other place, it might appear grade 2. But there have been studies which have tried to understand this heterogeneity. And they say that the maximum heterogeneity is seen in grade 2 tumors, and more heterogeneity is towards there being grade 3. So if you have a grade 2, and if you start sampling from various places, it is possible that you will find more of grade 3 features in a specimen which has been labeled as grade 2 rather than coming down in the grade. So it will be more likely grade 3 with grade 2 rather than grade 1 with grade 2. Coming to the molecular imaging, as we discussed at length, I think during the exam, the SSTRs, as short form as we can call, so various molecules are available, gallium labeled, DOTA-TATE, DOTA-NOC, DOTA-TOC, NODAGA, and so many others. They do alter the management in these patients in up to about 40%. They should be the first line imaging for staging for pancreatic neuroendocrine tumors. And as we did emphasize during our discussion, it should be performed for every patient prior to any surgical decision. It is kind of mandatory today. Various features which need to be picked up. I'm not going to go into the details. A radiologist will tell you. For these cells, the neuroendocrine cells, which for some reasons, 2 to 5% who do not exhibit somatostatin receptors may still have some dopamine carboxylase, I think, inside their cells. And that is where the DOPA scan can help. It is the F18 DOPA. There is HTP also. These are for somatostatin negative cases. And I have just come to know, in fact, just about 5 days back, that now F18 labeled Dotanoc will also be available in India, and the nuclear medicine oncologists will start using that. FDG PET is not the primary test for well-differentiated tumors, as was highlighted by Dr. Sandeep. For poorly differentiated neuroendocrine neoplasms, FDG PET is required, and therefore you might have to undertake a dual tracer study. And it is particularly more sensitive to pick up lesions wherein the Ki-67 index is more than 15 to 20%, and it is used as a good tool to understand the response to PRRT in such patients. I think because of the time paucity, I'll not show you the case details that I've included, because we have already discussed the cases and some videos which were there, which I will I think omit because we are already short of time. This is the basic therapeutic strategy regarding the pancreatic neuroendocrine neoplasms. So if you have a grade 1 or 2 tumor, and if you find it resectable, you go ahead and resect it if the tumor is more than 2 centimeters. And I'm going to take this up in slight bit more of detail after this slide as to what are the opinions or the guidelines or the accepted versions for tumors less than 2 centimeters or more than 2 centimeters. But anything which is less than 2 centimeters and non-functional, picked up incidentally, you can consider watch and wait. Mind you, it is not wait and watch, it is watch and wait, which means that you have to be proactive in monitoring and following up these patients. And if it is more than 2 centimeters, you have to resect it out. If the lesion is not resectable, and there are no liver metastasis, the patient goes for systemic therapy, which would mean, because the patient, it is not resectable and it is a disseminated disease, extrahepatic metastases are there, patient goes in for an oncological treatment with various sorts of chemotherapy that an oncologist can decide. But if you have a liver metastasis, there is a schema which has devised the load of liver lesions, and I'm going to mention it later. And based on that, one can decide what kind of liver therapy can be considered in terms of surgery or transplant or ablation or SIRT or transarterial embolization or chemoembolization. But if it is grade 3 neuroendocrine tumor and it is resectable, you would still consider it for resection. And it is not resectable, you subject the patient for what you can call, neoadjuvant or sometimes even maybe PRRT. For neuroendocrine carcinomas, by and large, there's no place for surgery, and these patients go in for further chemotherapy. Now, trying to discuss some various scenarios. For primary tumors, pancreatic neuroendocrine tumors, as I mentioned, non-functional, but more than 2 centimeters, there's no controversy. They need to be resected. For functional tumors, whatever is the size, they need to be resected. When it comes to less than 2 centimeters, various studies, more than 100 studies, various groups, more than 4 guidelines, confusion between 1 to 2 centimeters, some say less than 2 centimeters, some would say less than 1 centimeter, some would depend upon Ki-67 index, some would depend upon the manifestation of invasion or metastatic disease. But overall, the fact remains for all of us, for clinical practice, that for anything which is less than 2 centimeters and is not functional, the initial observation without a plan for immediate surgical resection is an acceptable treatment strategy for asymptomatic patients. And for these patients, biopsy is not routinely necessary to confirm the diagnosis prior to making a decision for observation. You can simply just wait. Don't be invasive. Don't flick the tumor and then wait. If you've decided to wait, just wait. But wait watchfully. The decision to observe or resect an asymptomatic pancreatic neuroendocrine tumor, which is between 1 to 2 centimeters, it should be individualized. And this individualization has to be based on the estimated risk of symptom development, details of imaging, grading, extent of surgical resection that might be required. So you might want to wait on a tumor which is right in the center of the uncinate process of the head and avoid ripples, with patient's wish, and of course, the access to long-term follow-up. So all of these factors will decide whether you should go ahead with the surgical treatment or just wait. When it comes to functional tumors, proper classification, of course, that will be based on the patient's manifestations, the endocrine syndrome, ruling out the presence of various syndromes like MEN1, staging, ruling out distant metastasis, and then pathological examination to determine the Ki-67 index. As far as the functional tumors are concerned, the risk of malignancy in these tumors are concerned, gastrinomas, glucagonomas, and tumors that secrete VIP, parathormone, or ectopic ACTH, they have a very high risk for being malignant, up to about 60 to 90%. Whereas for insulinomas, this risk is about 5 to 15%. When it comes to biochemical cure and recurrence properties of these tumors, if it's a localized insulinoma, it results in about 98% biochemical cure rate if you just take it out. And the recurrence at 10 years is just about 6%. So insulinomas do very well and favor a good surgical result. But when it comes to gastrinomas, the biochemical cure, despite removal of the tumor and all negative studies on follow-up in terms of imaging and biochemistry, 60% of these patients will still manifest high gastrin levels, and patients might still have the same symptoms, though to a lesser degree. And at 5 years, 30 to 40% of these will recur, and only about 15% survive for 15 years. And this is despite complete clearance at the time of primary presentation and the primary surgery. When it comes to regional nodal clearance, in gastrinomas, it is important to have a lymph nodal resection in each and every case based on the morphology and the location of the tumor. And at this point of time, the nodal clearance policy has to be in concordance with whatever is the nodal clearance policy for adenocarcinoma in that part of pancreas. When it comes to trying to localize these tumors in patients where there is a clinical syndrome and a biochemical suggestion, but the tumors are not getting localized, SSTR PET CT can be useful to identify these tumors with a sensitivity of almost about 100%, specificity of about 57%, and accuracy of almost about 95% when it comes to non-insulinoma P entities. But when it comes to insulinomas, SSTR PET CT might not be all that much sensitive or specific, and there you might need exendon scans, which are more sensitive and pick up these lesions. I recently, about 3 months back, we had a patient who had hypoglycemia, who showed an insulinoma on a CT scan that was done elsewhere. The patient was referred to us. We could see that lesion on that CT scan. Because I was not sure about the vascular invasion, we repeated a CT scan, a pancreatic protocol. We could not find anything. We did an MRI. We could not find the lesion. Insulin levels were very high. We did a Dotonoc. We could not find a lesion. We did an exendon scan. We could not find a lesion. And then our endocrinologist did an antibody test and finally diagnosed it as antibody-mediated hypoglycemia, hyperinsulinemia. And it was later understood that it was perhaps post-COVID vaccination. So such kind of fallacies do occur, and it is very, very important then that when you have a functional patient, you must have all the imaging in place and have the strategy in place. When it comes to familial neuroendocrine tumors, less than 1 centimeter can be observed. More than 2 centimeters should generally be resected, same guidelines. And functional should also be removed. And when it comes to gastrinomas, particularly in the setting of familial neuroendocrine tumors, medical management may also be considered, because in these patients, biochemical cure is not very common, and they tend to complain of hyperacidity and reflux in more than 60% of these patients, and the serum gastrin levels remain high. We were discussing about the spleen-preserving distal pancreatectomy for pancreatic neuroendocrine tumors. Indications, of course, are the low-risk sporadic pancreatic neuroendocrine tumors, and these are unlikely to have occult nodal metastasis. These patients are predicted to have long survival, and it should be considered in young patients who develop pancreatic neuroendocrine tumor. And if you might remember, I might actually show you the picture, maybe later. So I think about a month back, we demonstrated that live when we did a 4-5 centimeters tumor in the body of pancreas going into the mesenteric base, wherein we did a spleen-preserving distal pancreatectomy, because the patient was a young orthopedics doctor, just about 24 years of age. So it has a definite role in the armamentarium of a surgeon. And it is important, as Dr. Randhir had pointed it out, taking the spleen out when it can be saved might predispose the patient to an increased risk of septicemia, pancreas and bladder cancer, as well as pulmonary embolism. And this has been shown in a large cohort of American veteran patients in long-term follow-up after splenectomy, which was actually performed for those patients following a trauma. Regarding enucleations, for small tumors in the pancreatic head, it might help us avoid pancreatic chordorenectomy. Functional tumors like insulinomas are very commonly amenable to enucleations. Contraindications might include larger lesions, which are more than 3 to 4 centimeters, or the tumors which are in vicinity to the main pancreatic duct. And the guidelines from the NANET agency mention the same criteria almost. So I'm not going into the detail, but important is, if you are considering an enucleation, please do sit down with the family and consider the risk of postoperative pancreatic fistula, which might induce some morbidity and might take some time for the patient to recover. I mean, of course, this is the cost of trying to save some parenchyma of pancreas, but then this complication has to be discussed, and each of these patients should undergo an MRCP. And if you find that the lesion is close to the pancreatic duct, please, if you're attempting it, have a good detailed discussion with the patient. But it will be better if you consider a resectional patient in these patients who have an NET close to the pancreatic duct. I'm not showing the video. This was my first insulinoma almost about 14 years back, I think. When it comes to margins, as to what kind of margin you should have when you're doing a resection, be it enucleation, be it a distal pancreatectomy, resection with negative margins should be the goal, but there are no data to support that more aggressive resection to obtain wider surgical margins is justified for pancreatic neuroendocrine tumors, and therefore enucleation is an acceptable option in select patients. So you do not need a 5 millimeter margins, even a 1 millimeter margin is good for insulinomas. And coming to the central pancreatectomy, the median pancreatectomy, it is a good option for young patients for deeply located small, benign, or low-grade PNETs in the pancreatic neck proximal body. Lymph node sampling will have to be done based on what is the primary histopathology that you are expecting. These are functional tumors. For insulinomas, you might consider avoiding if there are no lymph nodes seen on these scans. But if it is something else, you might have to consider the nodal dissection along with that. So I'm not going to the case details because this might take some time. And we have, I think, discussed all of these things. This was a central pancreatectomy. I'm trying to omit the video also. But then these are good options, and you can see you can consider median pancreatectomy in these patients with a very good outcome. Most of these patients are young and in the productive age group. Also, of course, if you have very precarious lesions and you're trying, as I mentioned, if you're trying to avoid a very major procedure, we did this transmesocolic enucleation of an insulinoma from the uncinate of a young boy. And the next year, I did the median pancreatectomy or the central pancreatectomy on his sister. And the next year, both of them underwent a parathyroid resection for which they had actually become symptomatic. This is the lap spleen preserving DPS that we performed in a workshop 1 month, I think 2 months back. You can see the big lesion, almost about 5 centimeters lesion coming onto the mesentery, but we could eventually do that. Well, the last issue is about the liver metastasis, and almost about, as I mentioned earlier, also 30 to 80% of these lesions may display a metastasis to the liver. Whenever possible, in any form, surgery is associated with the most favorable outcome, and it can also help as a good palliative option. But these decisions are guided by the tumor grade and the morphologic growth patterns of these lymph metastases. Just trying to revise the same chart as to how should you approach the liver metastasis. Not going into the details, but these are the types that have been described about the neuroendocrine liver metastasis. It has been divided into type 1, type 2, and type 3. I can give you the reference for those who are interested, who can go through these definitions and what forms of resections are possible or the surgical options are available in these patients. For the paucity of time, I'm not going to take it up in detail. But important is that there is a good median 5 to 10 year survival in these patients to the range of about 40%. And therefore, one must be very aggressive when dealing with neuroendocrine liver metastasis. Liver transplant can also be an option. And there have been reports in which post-liver transplant ablation and PRRT have been done, and patients are doing well even after 6 to 7 years. And of course, we have various ablative techniques, TACE, TARE, cryo, RFA, and SIRT. And of course, the PRRT, which can be taken up by an expert. I don't understand much about it. And so that probably brings me to the end of a brief synopsis that I could present to you. Once again, I thank the officers and Dr. Rao for inviting me over for this exciting meeting. Thank you.
Thank you, Dr. Bhojwani, for that detailed talk on the topic and giving references to the students who can later go on YouTube, view these slides again, and read up in detail. This brings us to the last segment for today, which would be for the experts. We have 4 questions today, and I think a couple of them have already been covered in detail. But we'll just brush them over in short. So the first one is functional tumors with diagnostic supporting biochemistry. Do we need a biopsy to confirm the diagnosis in such patients? This question will post first to Dr. Sandeep Naik.
Srijan, what is the question? I couldn't get it.
Yeah, so functional tumors with diagnostic supporting biochemistry present, we still need a biopsy to confirm the diagnosis and plan management?
Like what? What tests are,
I think what they're
serum
trying to ask is gastrinoma or insulinoma. If we have raised markers, do we need a biopsy?
See, if you have something like a gastrinoma, gastrin levels are raised, you have a confirmed gastrinoma, I don't think you need a histological proof, but you need to localize the tumor, because that's where it becomes very important to have an appropriate test to localize it. And it can be multicentric also, there can be multiple gastrinomas. So these factors will matter. Localizing is more important. Diagnosis, of course, can be based on serum markers alone. But there are very few, like for example, functional tumors only you will be able to do that. You will not be able to do it for non-functional tumors.
Right. Dr. Bhojwani and Dr. Randir, any inputs?
Yeah, so because sometimes it is important. It will depend upon the morphology and what kind of biochemistry you're looking at. For insulinomas, it may not actually be required at some time. But if you're dealing with gastrinomas, it might be required because the tumors can be multifocal. That is one. Secondly, it is important if it is a multifocal tumor, it is important for you to know as to which lesion or which nodule is actually leading to symptoms or is secreting. There have been reports wherein there were multifocal insulinomas and one was secreting and the other was removed. For gastrinomas, the local recurrence or so kind of biochemical recurrence is to the tune of about 60%. So you need to be sure as to what you're dealing with. And therefore, I think it will depend on case-to-case basis.
Right. Dr. Randir.
As of now, there is no evidence except in HCC and with AFP raise, all others biopsy is mandatory. So as of now, evidence is not there. But if you ask me for few functional tumors, it may be the future that with PET-MR coming, we may avoid biochemistry biopsy before going for surgery. But it's still as of now, for students, it should be biopsy should be done. And in the type of gastrinomas also, we have type 1, type 2, type 3 gastrinomas, which you may be thinking that you are addressing the same gastrinoma, but that may be not grade 2 gastrinoma, grade 2 neuroendocrine tumor, that is of a specific type of gastrinoma secreting gastrin and all. So that's why we need biopsy as of now. We'll await for the future.
Right. Our second question first to Dr. Randir. What is the common cause of mortality that you see in patients with neuroendocrine tumors? And has that changed over the years?
The common cause of mortality in neuroendocrine tumors, apart from neuroendocrine tumor, other causes, pulmonary thromboembolism is one of the cause of mortality which we have seen, but disease progression, liver failure, and what do you say? Either treatment-induced side effects also have caused mortality. Like AML is documented in very rare, though rare, but it is PRRT. One of the side effects is leukemia. So all these and iatrogenic causes because of which patients have expired. So I will say the common cause of mortality in neuroendocrine tumors is most commonly and rarely carcinoid crisis. So the most common mortality would be disease progression and non-tumor, non-cause specific mortality.
Dr. Bhojwani and Dr. Nayak, any inputs?
Yeah, I think one would be the disease load, for example, liver failure. The other would be the biochemical load, like say carcinoid crisis. And third, in cases of neuroendocrine carcinomas, it will be like any other carcinoma of the peritoneal dissemination, ascites, and multi-organ failure. So I think these three would be important.
Our third question is, I'll post that to Dr. Bhojwani first. How to sequence surgeries when you have multiple organ involvement in these syndromes? Yeah, so when we are talking about particularly the MEN syndrome, MEN1 syndrome, it all depends on what kind of lesions the patient has. We have had patients wherein we have simultaneously taken out 3 parathyroid
adenomas and done a distal pancreatectomy on table. In one patient, we did enucleation. So parathyroid and pancreas can be combined, of course, depending on your facility. But maybe the pituitary tumors will be dealt with later by the neurosurgeon before or later, depending on whichever is producing symptoms. Regarding the other syndromes, von Hippel-Lindau syndrome, I had a young boy, an IITian, who earlier underwent an eye surgery and then hemangioblastoma in the brain. And then I did I think, distal pancreatectomy. And then he underwent a robotic nephrectomy, partial nephrectomy, because he developed a clear cell carcinoma. So I think it will all depend on what all is there that needs to be taken out, whichever is symptomatic and which can be conveniently combined at the time of primary resection without increasing morbidity. Again, it will have to be, on a case-to-case basis.
Dr. Naik?
I think Dr. Bojwani has covered it well. He's brought out all the points. Basically, it depends on the symptoms of the patient, and how we can do the surgery with causing least morbidity to the patient. So we'll have to basically look at all these parameters and then sequence it, because there are many times when we can do two surgeries together without causing too much more morbidity. So it's possible, it's feasible. So those combinations will have to be thought of and taken forward.
Our last question, which I think Dr. Bojwani covered in detail in his talk. If we have an asymptomatic patient with multiple tiny nodules in the duodenum and the biopsy comes as neuroendocrine tumor grade 1, we know now from his talk that we can keep this patient under follow-up and keep him for watch and wait. So I'll just modify this question a little bit for our examiners, and that would be, would we want to do anything else in this patient before we send him for surveillance? Should we be looking at his calcium, PTH, and all the other tests that we also spoke about? So
yeah, we have to rule out the syndromic associations for sure.
And post that, regular endoscopic follow-up.
Yeah.
See, nowadays, I think, duodenal well-differentiated NETs are being picked up quite commonly because of endoscopies being so rampant, everybody's getting it done. So, and most of them below 1 centimeter, I think mostly we would be keeping them on follow-up, and many of them probably are associated with PPIs also. We don't know. I mean, it's just that, we don't see anything else in those patients. It may be just the PPI overindulgence which may be causing it. So I think that is by far, most of these can be kept on follow-up.
Yeah, but there can be specific situations where they might, because there are many reports by the endoscopists where they have now gone ahead. If they're finding only a single lesion which is less than 1 centimeter, they go ahead and do the AMR.
Yeah.
In other situations, we have had 2 morbidly obese patients who had 1 nodule in the duodenum, so we combined the procedure. We in fact published it. So there can be various clinical presentations, and as I mentioned during my talk, it has to be discussed with the family on a case-to-case basis. There can be so many other factors which may not cover the scientific aspects, which might determine whether the patient should undergo surgery, not surgery, or just watch and wait.
Even other option for many of these patients in multiple is to do a duodenotomy and do an on-table ultrasound and pick up these nodules and resect them. So that is another possibility. In a limited cases, you don't even have to do Whipple's procedure in these patients. It's possible to do duodenotomy and get away with a lesser procedure.
Right. Thank you, all the 3 examiners, for answering these questions in so detail and with so much patience. This brings us to the end of our webinar today. I would like to first thank both the examinees and all the faculty to giving us their time and covering this heterogeneous wide topic. I hope the participants consider this as a primer and go back and cover all these various aspects in detail. and all of us can get a bit wiser to that. I invite Dr. T.S. Rao to kindly deliver the vote of thanks for today.
Thank you. Thank you for the invitation.
I thought it was an excellent 2-hour session. Both the students were very well read. I'm sure that they'll do well in the exam, not just the exam, but in future also. And the moderation was so controlled and so crisp. Sandeep, you really stood up to the expectation.
Thank you, sir. Thank you for
and
having
and an excellent teamwork. I think you all combined so well. Randhir, generally when we bring in non-surgeons here, there can be not just voice but noise also. But that is something that did not happen. You really contributed so well. You went on chipping in between, and it was very, very informative. Rajesh actually told us that he himself learned a few good things from the diagnostic part of it, and that is directly a compliment for you. And that if that comes from somebody who's Rajesh Bhojwani, who is one of the real great scientific surgical brains in the country, I think it's quite an achievement. And Rajesh's expert talk is something that will be watched by students and faculty for a very, very long time. I would want to tell Rajesh and Randhir that Sandeep actually follows these master classes. These are watched by innumerable number of students and junior faculty multiple times. And there are enough number of people who actually, whenever we go to a conference, and that includes Jaipur conference of Rajesh, they come and tell us, sir, the classes have been excellent. I passed so-and-so exam outside the country by just listening to these. So I think very well done job. Thank you very much. And IASO understands your value and will make use of your wisdom and academic brilliance. Thank you very much. Goodbye and good night.
Good night, everyone. Our next meeting is on 11th of August, same time, 7 p.m. And the topic for the next meeting is hereditary colorectal cancer syndromes. Thank you for joining in. Have a good night.
Thank you. Thank you. Good night.
Thank you.